Hello, everyone, and welcome. My name is Ishel Rosal, and I serve as the Senior Associate Vice President for Student Life in the Division of University Life. And University Life is a hub for student life at Columbia, supporting all students across all schools and campuses through resources, events, and initiatives that support inclusion and belonging, health and well-being, and community citizenship. I want to thank you all for joining us for today's event, Am I Alone or Lonely? Exploring Loneliness and Its Impacts, which is co-sponsored by Columbia Health. In 2023, the U.S. Surgeon General declared loneliness an epidemic, with more than half of adults experiencing significant levels of loneliness or social isolation. The impacts of loneliness are far-reaching and can have an impact on both personal and collective well-being. To help us better understand loneliness and its effects, we are joined today by Dr. Wei-Yin Chung. Dr. Chung is a clinical psychologist at Columbia Health's Counseling and Psychological Services. Her clinical interests include neurodevelopmental disorders such as autism spectrum disorder and ADHD, trauma, anxiety, depression, and acculturation. Before coming to Columbia Health in 2019, Dr. Chung completed her postdoctoral training in the Bronx at Astra Services for Children and Families in their outpatient day treatment programs. She also completed clinical externships at a public high school in both outpatient and residential settings, where she treated patients with adjustment issues, family and relationship conflict, depression, anxiety, and self-harm behaviors, as well as survivors of physical and sexual abuse and veterans with substance use issues. Dr. Chung is passionate about creating a safe and collaborative environment while integrating mindfulness and cognitive behavior therapy strategies. We are so thankful to have her here today to help us explore today's topic. Welcome, Dr. Chung.
Thank you, Ishel. Hello, everyone. My name is Wei-Yin Chung. As you've heard, I'm a licensed clinical psychologist, and I work at Columbia Health's Counseling and Psychological Services. I'm very grateful to be here today to talk about loneliness. As we'll see, or maybe you already know, it's become an epidemic that I think we need to be talking about more as a community. As the title of today's presentation suggests, I'm first going to outline some helpful definitions and terms as we explore this topic. I will then review some statistics and research about why we're discussing this today, as well as factors and cultural experiences that have contributed to the loneliness epidemic and the impact of loneliness on health. I'll also specifically talk about loneliness on college campuses, including strategies on an individual and community level for us to try and foster and build connection. I wanted to also provide a disclaimer that some of the data I'll be presenting includes data on suicide and self-harm. Much of what I'll be covering today is outlined in the Surgeon General's advisory on the effects of social connection and community that was published 2 years ago and really was eye-opening for me in understanding the significance of loneliness and the breadth of its impact. But I also expand on other research that you'll hear about. So let's first define loneliness. You might have heard this phrase, being alone does not mean you are lonely, and being lonely does not mean you're alone. The difference being that alone is a state of being versus a subjective experience of loneliness. Most of us will feel lonely at one point in our lives, but loneliness can become chronic, developing over time to a sense of hopelessness about social relationships and interactions. When there's been a pattern of efforts met with disappointment, this can lead to a feeling of defeat and hopelessness. And then it becomes easier and easier to withdraw and spend time alone. Loneliness has been likened to a social deprivation or starvation, like walking through a desert, like the image shows, and desperately thirsting for water, but without any respite or oasis in sight. And neurologically, in the same way that our brains respond to hunger, our brains also respond to loneliness and usually drives us to seek connection, but more on that later. So sometimes the terms feeling alone and lonely are used interchangeably. However, the definition of loneliness that I'll be using today is that subjective, often distressing experience that's fueled by a perception of isolation or having inadequate, meaningful, or quality connections. For today's discussion, I'll also differentiate between being alone and social isolation. Social isolation being defined as an individual objectively having few social relationships, roles, or group affiliations. I also wanted to define social connection. As you can imagine, social connection is not just the number of people in your social support system. It's more complex than that. Holt-Lundstad identified 3 key components that comprise this umbrella term of social connection: structure, function, and quality. Structure encompasses the number and variety of relationships, such as number of friends, household size, romantic relationship status. Function involves the degree to which relationships can support our various needs, such as whether we can receive emotional support or financial support, physical safety, or mentorship. And quality is the degree to which our relationships are perceived as positive, helpful, or satisfying, or on the opposite end of the spectrum, negative and unhelpful or unsatisfying. So Holt-Lundstad suggested that social connection is based on this continuum, as we're understanding many things are, such as gender identity and autism. But this continuum is dynamic over time and may shift in either direction based off of stressors, life events such as moving, loss, marriage, jobs, political climate, and world events such as war and the pandemic. So why does this matter? I have the privilege of a full hour with all of you today. Why is this what we're discussing? First of all, social connection is a basic human need. Our brains are wired to want and expect social connection. And historically, our ancestors leaned on one another to be able to hunt for food, find water, and shelter, and was important for our survival. Loneliness and isolation are associated with dysfunction in the brain reward circuit, or the ventral striatum, which regulates motivation, and the limbic system, which regulates stress responsiveness. And these areas have showed reduced brain activity when lonely individuals were presented with social stimuli. Animal models have also shown us that social interactions are primary rewards, operating through that same dopaminergic system, the brain reward circuit. And that social interactions are inherently pleasurable and motivate behavior, and that social isolation leads to severe changes in behavior and brains of animals, particularly during neurodevelopment, which, by the way, in humans continues on until your mid to late 20s. Research has shown that social isolation in animal models increases the drive for other rewards, such as substances. An example of one study showed that 60 minutes of daily social physical interaction among rats was a protective factor to morphine consumption in socially deprived rats, which suggests that individuals may then turn to substances or even excessive screen time in attempts to stimulate that reward system when feeling lonely. However, there's caveats to this research in that it can only be correlational and is still unclear whether these findings are consequences, causal, or risk factors. So we're also talking about this today because it's actually, and it's by it's I mean loneliness, is more common than we probably think it is. A study from 2022 told us that half of adults experience loneliness. Conversely, less than 40% of adults identify feeling connected to others. Both younger and older populations experience the highest rates of social isolation, But young adults have the highest rates of loneliness. In fact, young adults are twice as likely to report feeling lonely compared to those over 65. To put this into context, loneliness and isolation is more widespread than smoking, diabetes, obesity, with comparable levels of risk to health and premature death. In addition to age, essentially all racial and ethnically diverse groups were more likely to report loneliness than non-Hispanic white individuals. And those who ended education at high school and those who have a household income of less than $25,000 were also more likely to report loneliness. Individuals belonging to the LGBTQ+ community are more likely to experience loneliness than their cisgendered heterosexual peers. However, there has also been research that's been variable regarding gender and loneliness. Some have shown us that loneliness is more common in women than men. Some have shown men may be more commonly lonely, and some indicate no significant difference. A recent study from this year by Barreto et al. Suggested that these varying findings might be related to the wording of questions and gender differences and stigma related to acknowledging loneliness. Those also with physical limitations, disabilities, or having experienced interpersonal violence are also at higher risk of experiencing loneliness. Considering culture and its interactions with loneliness has been challenging. One might assume that a collectivist culture may be better socially connected than individualistic cultures. However, what research has shown us is that it's likely more complicated than that. What we do know is that the experience of loneliness occurs across all cultures, with individualistic and collectivistic cultures having comparable reports of loneliness. The differences lie in the experience of loneliness, in that individualistic cultures see loneliness as a personal separateness or a social isolation, and by contrast, in collectivist cultures, loneliness was related to a lack of understanding of one's views or feelings. Suggestions on how we study culture and loneliness have outlined that there are intricacies cross-culturally in terms of cultural meaning-making that shape loneliness, as well as differences in coping with loneliness. Now that we know how prevalent loneliness is, let's talk about the impact it has on health. We've learned that loneliness is associated with greater risk for a multitude of health concerns, including cardiovascular disease, dementia, stroke, diabetes, viruses, respiratory illnesses, and premature death. Studies have indicated that poor social relationships were associated with a 29% increase in risk of heart disease and a 32% increase in risk of stroke. We have learned that social disconnection has been linked to increased risk for development of type 2 diabetes, whereas social connection has proven to improve health outcomes in type 1 and type 2 diabetes. Research suggests this may be explained because those who are better socially connected engage in more self-care behaviors, such as adherence to medication, diet recommendations, and regular body movement. We also know that less socially connected individuals have a greater susceptibility and weaker immune response when exposed to infectious diseases. For example, in a study on the common cold and flu, loneliness and poor social support were found to significantly contribute to both the development of those illnesses as well as the severity of those symptoms. Studies also showed that more socially connected individuals have stronger immune responses. We know that loneliness and social isolation have been associated with faster rates of cognitive decline and increases the risk for dementia by 50%. Even when controlled for factors such as demographics and health status. A few small studies have indicated that loneliness does not have an impact on duration of sleep, but does have an impact on quality of sleep, or what's called sleep fragmentation, described as micro-awakenings or micro-arousals. Exploring the impact of loneliness on mental health, such as depression and anxiety, is difficult to tease apart because one of the common symptoms of depression and anxiety is social withdrawal, which increases the risk for social isolation and loneliness, but social isolation and loneliness can also predict increased risk for developing depression and anxiety, creating a sort of feedback loop. We have seen that the likelihood of developing depression in adults more than doubles when feeling lonely often. Furthermore, we have seen that there's a significant relationship between social connection and self-harm and suicide, in that loneliness and social isolation are associated with self-harm and suicide, while social connection can be a strong protective factor against self-harm and suicide. So while we have seen that socially connected individuals live longer, one of the first longitudinal epidemiological studies that spanned 9 years back in 1979 showed that social isolation led to more than twice the likelihood of mortality during that period of time when controlled for age, health status, socioeconomic status, and health practices. And to paint a more explicit picture, a meta-analytic review in 2010 across 148 studies and an average of 7.5 years of follow-up found that social connection increases our survival odds by 50%, and that the dangers of lacking social connection are worse than smoking up to 15 cigarettes a day. So this makes you wonder how. How is it that loneliness and social connection has such a profound impact on our health and well-being? Holt-Lunstad outlined 3 pathways in which social connection can influence health, as shown in this figure from the Surgeon General's advisory. Those 3 principal pathways Holt-Lunstad outlined were biology, psychology, and behavior. Taking a closer look at biological pathways, research has documented that social connection can influence our cardiovascular, neuroendocrine, immune, and gut microbiome functioning through the interactions of blood pressure, hormones, and inflammation. For the past 2 decades or so, inflammation has become a hot topic as the culprit of many chronic illnesses such as diabetes, dementia, cardiovascular disease, and including mental health disorders. For some context, inflammation is just our body's natural defense response to stress and injury, but too much or too little of an inflammatory response or chronic low-grade inflammation can increase the risk of chronic illnesses. Studies have told us that social isolation and lower social support is associated with higher inflammation, and in some cases to the same degree as physical inactivity. On the other hand, social connection seems to improve biomarkers of cardiovascular functioning and better regulation of the neuroendocrine system, particularly the role of oxytocin when forming attachments in early ages as well as adulthood. We've also seen that there may be genetic differences in those who are lonely versus not. Twin studies have estimated that heritability of loneliness is between 37 to 55%, particularly with personality factors such as neuroticism, shyness, and depressive symptoms. Research has shown that loneliness is associated with increased stress response via the hypothalamic pituitary adrenal axis, or the HPA axis, which in turn alters gene expression and impacts inflammation, immune response, and cardiovascular issues. A study found that 209 genes related to immune system and inflammation were overexpressed, and those genes regulating antibody production were underexpressed in lonely individuals. Our understanding of the influence of psychological processes on health involves the way we make meaning and a sense of purpose. Research has told us that those who have a higher sense of purpose, meaning, and perceived support are more likely to engage in health-promoting behaviors, as I previously mentioned, since adults generally across the world rate their relationships with family and close friends as the most important source of meaning, purpose, and motivation. We also know that being more socially connected reduces the likelihood of perceived stress, which allows us to cope with that stress and minimize the impact of stress. Chronic stress has been shown to contribute to disruption in neurodevelopment, increased risk for mental health conditions, and other physical health conditions such as cardiovascular disease and diabetes. But being more socially connected can buffer against these effects. Social connection is positively associated with health-related behaviors such as diet and exercise, as well as sleep, as I've mentioned, but also other behaviors such as treatment adherence. The influence of social connection on behavior can include social norms such as getting vaccinated or wearing masks during the pandemic. And social connection can also more directly affect behaviors like a family member encouraging you to go to the doctor or a friend encouraging you to seek therapy. A clear example of this in research is that people are more likely to stop smoking when their social supports stop as well, and vice versa. Individuals are less likely to stop when their supports also smoke. Knowing these pathways of social connectedness and health, researchers have naturally wondered, how did the worldwide COVID-19 pandemic affect loneliness? We saw the pandemic's effect on an individual, familial, and community level. As I know we can remember, the pandemic was a time of loss in many different ways. We lost loved ones, lost in-person interaction. We lost the way we celebrated milestones like graduations, weddings, birthdays. It was a time of grief, sadness, anxiety, and fear. And not only did we lose loved ones to the illness itself, but we might have also lost relationships over polarizing views on whether or not it was even real. Studies have shown that mental health symptoms rose more sharply from 2019 to 2021 as the pandemic unfolded. One national study found in the fall of 2019, or pre-pandemic, that about 10.8% of adults ages 18 and older reported symptoms of depression and anxiety. However, in February of 2021, the prevalence increased to 41.5%. We also know that Indigenous, Latinx, Pacific Islander, and Black Americans, as well as essential workers, lower socioeconomic communities, and the elderly were disproportionately impacted by COVID-19, not just in terms of rate of infection and death, but also access to education, access to healthcare, increased rates of housing and food insecurity, and unemployment. So we know that decreased social connection is not a new concern, and in fact, social connection has been declining for decades. However, most studies have shown that the pandemic accelerated this. What we did see is that across the country from 2003 to 2020, from a study by Kanan and Veazey in 2023, was that average time spent alone increased from 285 minutes a day in 2003 to 333 minutes a day in 2020. This means an increase of 24 hours per month spent alone from 2003 to 2020. We also know that social participation declined. The amount of time spent with friends in person decreased from 60 minutes a day to 20 minutes a day. This meant a decrease of 20 hours a month from 2003 to 2020. The decline was the most significant in young people aged 15 to 24 because individuals in this age spent 70% less time in person with friends, going from 150 minutes a day in 2003 to 40 minutes a day in 2020. This is significant because throughout the pandemic, young adults consistently reported the highest levels of depression and anxiety symptoms compared to any other age group, such that nearly half of young adults reported symptoms of depression and anxiety in a given week, and also reported the highest levels of loneliness compared to any other age groups during the pandemic. The number of close friendships also declined over several decades, but has been accelerated by the pandemic too. Nearly 90% of people who have reported having 3 or more confidants prior to the pandemic, whereas in 2021, less than 50% of Americans reported having 3 or fewer close friends. In a review of 13 longitudinal studies, nearly all studies showed an increase in the trajectory of loneliness from pre-pandemic to during the pandemic. However, one study out of Germany assessed daily levels of loneliness and found a temporary increase in loneliness only during the initial phase of the pandemic, so from March to April of 2020, but returned to pre-pandemic levels. And another study from the UK also found variable levels of loneliness during the early pandemic from March to May 2020. But this makes me wonder whether varying responses to COVID-19, including social distancing requirements and mortality rates in different countries, may have played a role in those differing results. Another study found that from June of 2019 to 2020, there was a 16% decrease in social network size. Bucher and Horstman found that during the pandemic, there was a reduction in perceived quality of social relationships. However, a national study showed that by April 2021, 1 in 4 individuals reported feeling less close to family members compared to the beginning of the pandemic. Yet, at the same time, about 1 in 5 said they felt closer to family members, perhaps indicating that the pandemic exacerbated existing family dynamics of connection or disconnection. So here I just include some figures from the Canaan and VZ 2023 study for just a more clear visual representation of the increase in social isolation and the declining trends of social engagement across various types of relationships. So we've now looked at the pandemic and its effect on loneliness, but with advances in technology, algorithms, access to phones, required use of technology for school and work, we have to also wonder how this has affected our social experiences. In a study by the Harvard Grad School of Education's Making Caring Common, or MCC project, 73% of participants attributed loneliness to technology, and more specifically that, quote, people are so distracted by or used to technology that their in-person interactions are suffering. Owning a smartphone rose from 35% in 2011 to 77% in 2017. On average, we spend 6 hours a day on digital platforms, and 1 in 3 adults report they're online almost constantly, which makes sense given our shift to working virtually in schools and workforce. Binge watching, particularly autoplay functions on Netflix, but also including Reels on TikTok and Instagram, can be a coping mechanism for stress and distress, as I've mentioned before. Remember the reward dopaminergic system that I talked about. However, this kind of binge watching can lead to disrupted sleep, less physical activity, and lead to increased social withdrawal, isolation, and loneliness. In terms of social media use in particular, use by adults has risen from 5% in 2005 to 69% by 2017, and is even higher at 86% for young adults aged 18 to 29. The tricky thing about social media is that it can both be supportive to a person's mental health and be detrimental. Social media platforms like Instagram, TikTok, Facebook, Twitter, or X can positively contribute to increased awareness, destigmatizing mental health, as well as community building functions such as interest or identity groups. We saw this with social media use during the pandemic in particular, and its use during that time was described as a double-edged sword, that it could help promote mental health, but overuse was detrimental to mental health. What we found is that those who use social media for more than 2 hours a day had double the odds of reporting increased perceptions of social isolation compared to those who use social media less than 30 minutes a day. 56% of young people have shared that, quote, seeing friends having fun on social media has a negative impact, or as the kids say these days, FOMO. Most studies have shown social media use to be linked to loneliness, particularly when making negative judgments of themselves compared to others online. Social comparison can be adaptive in that it can help with social learning, and can be a motivating factor, particularly with work or academic performance. However, becomes problematic when that comparison is associated with a negative judgment about oneself. This is exacerbated in social media by use of photo filters that distort photos of faces and bodies to promote unrealistic standards of beauty, often leading to body image issues. That being said, some types of social media interactions have been found to mitigate negative impacts on mental health. For example, positive or funny experiences, one-to-one communication, or self-disclosure in a mutual online friendship mitigated loneliness and stress. Determinants of whether social media use is helpful or detrimental seems to depend on personality style, extent of use, and response from others. A study in Australia found that extroverted individuals seemed to enjoy social media use, while introverted individuals experienced more loneliness, depression, and lowered self-esteem. Which brings me to AI. I can't help but consider the case of Sewell Setzer III, and I'll preface this with a trigger warning for suicide as I briefly discuss his case. For those of you who may be unfamiliar with his story, he was a 14-year-old ninth grader from Orlando, Florida, who had been interacting with an AI chatbot for several months and had developed an emotional attachment, and began to spend more and more time on his phone, becoming more and more isolated, and was struggling with self-hatred and suicidal thoughts, which he had shared with this chatbot before then taking his own life in February of last year, which highlighted the lack of sensitivity and protection for those interacting with AI chatbots. What we know is that millions of people are using AI chatbots, and as of now, one only needs to be 13 or older with limited safety measures and considerations. Research about AI and loneliness is still limited and inconsistent. Some studies saying social chatbots have the potential to mitigate feelings of loneliness and social anxiety. Some have shown that social chatbots have helped stimulate other human relationships, while other studies have shown that use of social chatbots have led to worsened loneliness and isolation by replacing human relationships with artificial ones and lowering confidence in their social abilities to build human connections. A study exploring AI support in higher ed and impact on loneliness, student success, and retention found that students who reported feeling socially supported by people reported higher grade performance and were less willing to leave university compared to those who felt socially supported by AI, suggesting that those with more human connection were more likely to have greater academic success. All this is to say that despite its creators wanting to accelerate the accessibility and use of this technology, there is still much we need to learn in terms of how it can be supportive or harmful, and we need to take the time to consider ethical questions of whether or not we should be pushing towards normalizing artificial relationships. Moving on to exploring loneliness on college campuses, we know that loneliness during college is not a new phenomenon. College has always been a time of transition, loss of supports with family and friends in other states or other countries entirely. In a recent study by Active Minds of 1,100 students from 2- and 4-year colleges across the country, they found that 64.7% of college students reported feeling lonely. And these are students who were already feeling the intense disconnection and loneliness of the pandemic during their high school years, adding on compounding negative effects of increased social media use to create a perfect storm during a formative time of socialization skills and development of identity and self-esteem. LGBTQ+ students are particularly lonely at 70.3% compared to 60.6% of non-LGBTQ+ students, with one study indicating as high as 79% of trans and non-binary students experiencing loneliness. From a study by the Daily Trojan magazine at USC, 71% of students reported that college was lonelier than they thought it was going to be, and that 81% of those USC students said they had to seek out a strong sense of community and that it wasn't inherent to the college experience. We also know that students who have identified as lonely are 4 times more likely to experience severe psychological distress, including suicidal thoughts. It's been documented that loneliness on college campuses has contributed to increased odds of substance use, including benzodiazepines, marijuana, stimulants, and opioid misuse, and that, in fact, loneliness may contribute to suicidal thoughts through increased drug use in college students, which has implications for specific interventions for substance use on campus. While 62.7% of students believe that mental health is an important campus issue, only 50% believe that students are actively identifying mental health challenges, brainstorming solutions, or collaborating with other students and organizations to work together to improve mental health on their campus. Loneliness has also been associated with less shared concern about mental health and lower institutional valuation of mental health, which indicates the importance of a bottom-up and top-down emphasis on battling loneliness. Bringing it to Columbia in particular, I remember one of the first things I learned was how decentralized we are as a campus, meaning that there are institutional and structural factors that create barriers to community, much like what it sounds the USC students were feeling. I was able to find a student well-being survey through University Life in 2020 that showed that students were aware of the resources and used them, but that they found it challenging to share their experience with difficult issues, which suggests an area that we should focus on. It would be remiss of me to not mention the Israel-Hamas war and campus events from last year to now, and how those events and experiences might have affected social connectedness and sense of safety and community. I know that the National Opinion Research Center out of the University of Chicago had made efforts to recruit students for their survey exploring sense of inclusion and experiences with cross-cultural interactions, anti-Semitism, Islamophobia, and freedom of expression, but I'm not sure whether there have been any results yet. To capture what loneliness on campus might look like and how we might move from loneliness towards social connection, I've prepared a case to discuss with de-identified information. This isn't any one patient, but more an amalgam of common themes I've seen working with students and social connection through my years here. But as an example, let's consider this student, Michelle. She's a cis female, bisexual, 18-year-old freshman in CC. She identifies as Irish Chinese, first gen, and was born and raised in Chicago and just completed her first semester. Given what we know about the literature, she has several intersections of identities that make her susceptible to feeling lonely. She describes barely surviving through the fall, feeling so anxious, sleeping poorly, hasn't had her period in the past 2 months, and struggling with finding a support system, feeling lonely, and feeling all of this impacting her ability to focus and complete work on time. She had always been a straight A student, but has been struggling to stay on top of her work and has been performing at the class average and needed to hand in some assignments past the deadline during the fall, which makes her feel like she's failing and finds herself procrastinating with her work, has been staying up late at night to complete work, but also finds herself scrolling on her phone until late at night when she does go to bed. She talks about having a strong support system from high school, about 3 to 4 best friends, but they all ended up in different parts of the country, including back home in Illinois or on the West Coast. She describes herself as extroverted before getting to Columbia and has some friends here, but no one she feels comfortable with in the same way she did with her high school friends. They have different class schedules this semester and has been finding herself becoming more withdrawn, feels anxious and self-conscious going to the dining hall, and so eats in her room most of the time. She gets the feeling that the friends she does have don't like her and feels that she is always the one making an effort or reaching out, and feels like everyone has their group at this point except her. She feels close to her parents and talks to them every other day, but also feels they don't understand her experience as a college student at a competitive Ivy League and worries about burdening them. She had been a ballet dancer and had struggled with body image issues through middle and high school and felt she had gotten to a better place with her relationship with her body by senior year, but with becoming more withdrawn, scrolling more, she finds herself comparing herself to her friends on Instagram and feeling worse in her body. So as you can see, it's that perfect storm of loneliness that we talked about. So using our hypothetical student, Michelle, I'm going to outline what we can do on an individual level to explore loneliness and begin to seek connection. I'll preface this by saying there are many different therapist approaches. I incorporate cognitive behavioral tools that are evidence-based to be effective in treating loneliness. But the first thing that we can do is, like having this discussion today on loneliness, it's to talk about it. We have to continue to work to destigmatize feeling lonely, because one of the assumptions I hear most often, and let's say in Michelle's case, is that belief that I'm the only one feeling this way and don't want to burden others. Remembering that university life survey about talking about difficult issues. However, opening up to others can help us realize that we're not alone in how we're feeling and can help with feeling connected. With Michelle, we would begin developing a mindfulness practice. I think there are misconceptions about mindfulness being sitting cross-legged on the floor with your eyes closed. But really, the practice of mindfulness means being attuned to your thoughts, emotions, and physical needs. There are many proven benefits to mindfulness that span mental health benefits, physical benefits, and even include improved relationships. I would have Michelle begin journaling, and more specifically record common thoughts that get in the way when she's with friends. What we've learned is that lonely individuals pay more attention to negative social interactions and tend to interpret interactions in a more negative light, and was described by Dr. Louise Hockley, a researcher on loneliness, as, quote, the brain being hijacked. Of course, this assessment has to be done carefully and with a trained mental health provider, because we may have relationships that are not serving us. But from what I shared with Michelle's case, we can recognize that she was catastrophizing, thinking the worst case scenario, and assuming she knew what her friends were thinking about her. And unfortunately, research has shown us that the self-fulfilling prophecy is real and likely was contributing to Michelle's feeling self-conscious, not being her authentic self, and as a result, being more guarded and unable to feel close to others, or for others to feel close to her. Looking at our patterns in thinking as well as past experiences or messages can help us identify what a person's core beliefs are about themselves and the world around them, which is important because these beliefs fuel how we interact and perceive our interactions. In Michelle's case, some of those core beliefs were that she had to be pretty, cool, smart, funny to be liked, and that her self-worth hinged on her academic performance. And everyone else just sort of gets it and are doing it all. At this point, this is where challenging those negative thoughts and beliefs with self-compassion comes in. Self-compassion has been directly linked to loneliness and has been proven to alleviate feelings of loneliness. But what even is self-compassion? Self-compassion is being able to acknowledge painful and distressing experiences without judgment, but with kindness and understanding. So with Michelle, we would first explore and acknowledge where those negative thoughts and beliefs might have stemmed from, and consider, would I be saying this to a friend or a loved one? And if not, what would I be saying that would be kind, compassionate, and a more rational or balanced perspective? Once we can begin to do this is where we can start to think about setting goals to help improve Michelle's existing relationships and perhaps build new ones. An important part of setting goals is to have realistic expectations. I often hear students expect to have found their people in the first month of being here. But when we say that out loud and take a look at where that timeline even comes from, we can see that it's not the most rational or fair expectation to have for anyone. So at this point, we would first recognize that building social support system and meaningful connections takes time. I would have Michelle think back to how she built her relationships with her high school friends, which, by the way, is a much easier bubble to be able to build connection. And then we would recognize that those connections developed over years of daily contact and didn't happen in 1 month. A part of having realistic expectations is also to recognize that that hijacked brain isn't just going to suddenly go away overnight, and that part of this work is going to be to sit through the discomfort of putting yourself out there and challenging those negative thoughts and beliefs. When setting goals for social connection, research has told us to prioritize, quote, richer social experiences. So rather than a text message, consider a video call, an audio message, or an in-person interaction. In Michelle's case, once realizing that scrolling wasn't helping her relationships or her relationship to her body, and once realizing how her mood had become largely dependent on what she would see online, maybe she would eventually decide to take a break from social media. We might also set an intention for Michelle to ask friends what their schedules are to set up weekly lunches together. She might set up monthly video calls with friends from home, or we might have her set a goal to take a couple minutes at the end of one of her classes to talk to a peer and maybe eventually ask to get coffee. I would also eventually work with Michelle on moving towards vulnerability, meaning letting others in on how we're feeling, which can be intimidating and should be done gradually to sort of test the waters in our relationships, but can also lead to those deeper, more meaningful relationships. So maybe Michelle would begin to tell her parents how she was truly feeling, or she might begin to share with friends that things have been harder than she had thought they would be. I would also be thinking about other kinds of relationships I can be connecting Michelle to. Knowing about the intersections between health, stress, and loneliness, there is a chance that her poor sleep and missed periods could be related to that, but I would first connect her to medical services to rule out any physiological concerns we would need to address. I would also want for her to be connecting with her advising dean to see if there is academic support she can be receiving or ways we can mitigate academic stress, or maybe connect with disability. So I know that I'm running low on time, but this is, I do want to cover this last slide. What can we do on a community level here at Columbia? So researchers encourage tailoring resources to students' needs and identities, particularly those susceptible to loneliness, including our LGBTQ+ students, our first-gen students, low-income students, and targeting substance use. Firstly, I think there's a lot out there on campus in terms of ways to connect with others, so we don't need to reinvent the wheel. Particularly knowing some of that data from that well-being survey, that students are aware of what we have, and that we have 400+ student clubs, organizations, and teams. This month alone, University Life had 30+ events planned and upcoming, with sometimes more than one event in one day. So perhaps the issue instead is decision fatigue, to which I would say goes back to taking things one step at a time and having realistic goals. Maybe the first step is picking one resource website to look through, or contacting one student organization that aligns with your interests and values. Research has shown the benefit of creating regular spaces and opportunities for students to prioritize self-care, interact and socialize with one another. For example, some students from other college campuses have enjoyed speed friending. Duke has also introduced a program called QuadX, where all freshman students in a dorm will move together to the same sophomore dorm in order to build a sense of community the first 2 years. Research has shown that the most effective interventions to foster social connection are in group settings. It's important to note that these interventions don't need to be advertised as focusing on loneliness or social connection, but can be more broadly targeted to address well-being. And research has told us that policies that reduce academic stress has been proven to support students joining those group spaces. Since acknowledging loneliness has proven difficult for students, virtual group support offerings can be a promising way that might help it feel less intimidating. Recommendations for practice also include arming students with social skills and programs that help students help one another, such as programs focused on emotional literacy, peer coaching or mentoring, like the Friend-to-Friend group through Alice Health Promotion. As we covered the double-edged sword of technology, we have community policies and expectations in place that should protect from marginalization, bullying, and discrimination in digital environments. So the intention is not to ameliorate the use of social media, but to maximize technology that promotes social connection. One such example is the Nod app. I have to say that I have no stakes in this app, but came up through looking into interventions for loneliness on campuses. But it's rooted in evidence-based practices such as positive psychology, mindfulness, and cognitive behavioral practices, as well as self-compassion, and co-designed with students. And students or administrators can request to bring Nod to campus through their website. So as the research on college campuses on loneliness and mental health suggests, students see this as an issue, but fewer students are taking actions to address mental health concerns. What this means is we need a campus culture shift to taking action to combat loneliness and build social connection from that bottom-up and top-down approach that I'd mentioned. This means moving away from a culture of competition and performance above all to a culture of balance, well-being, social connectedness through prioritizing acts of kindness, respect, service, and commitment to one another. Prioritizing inclusion might look like easier access to a variety of student clubs and organizations, or taking a moment to say hi to that classmate sitting alone. But it also has to include campus programming and policies that mitigate academic stress, promote social connection and mental health. And I understand that that's no easy undertaking, but I implore you and us to shift our thinking to understand that caring for ourselves and one another doesn't have to compromise our pursuit of excellence and achievement, but can actually propel it. Lastly, implications for practice include amplifying student voices. As students here, you are the ones who understand the unique experience of the social environment here. If there's something you're interested in that isn't offered, take that step to start something new, which can be intimidating, but you might also find that others share those interests. As an example, if there's a group or a support space you don't see offered by the counseling service, you can email our outreach coordinator, Dr. Ann Goldfield, and we will always try our best to create some sort of offering to meet those requests. So I'm mindful of the time. I include some other resources and helpful links for campus resources, including Columbia Health resources, a photo of us to show that we're humans and you can connect with us, and we have a diverse team, our specific resources, other confidential resources. If we had had time, I would have done an experiential exercise, but thank you for being here.
We'll take some questions.
Sure, yeah, whatever we have time for.
Any questions?
Hi. Hello. I have one question. Which one is more dangerous, feeling loneliness, or being in an unhealthy community, or trying to fit in that community? Yeah.
I'm truthfully not sure if there's research out there so far that has that comparison. I think what we do know is that all of those things can come together and can be harmful in terms of a feeling of loneliness and its impact on our health and well-being. Yeah.
Do you have any advice for reframing the social interactions that you do have? I guess aside from negative thought patterns maybe, so that the gap between your perceived social interaction and it kind of narrows to fight the loneliness.
As I had sort of mentioned, I think the first step is just sort of being able to recognize what thoughts may be coming up for you in a moment like that, because then you can start to see that there are probably some recurrent negative or unhelpful thoughts that are getting in the way of feeling socially connected. So that would be my first suggestion. And then to sort of slow things down and try and challenge that hijacked brain by using deep breathing, to then be able to sort of stay present in the moment and just try and interact, as opposed to getting too up in your head and caught up in those unhelpful thoughts. Yeah, thank you for that question.
Thank you. If anyone had a question that they didn't have a chance to ask, you are more than welcome to reach out to University Life at columbia.edu, and we'll forward your questions on as well. But with that, thank you so much.
Of course, thank you all.